Hello everyone, it's Doc Kyle once again, and tonight we're gonna talk about disorders in iron kinetics. So simply put, disorders in iron kinetics is just problems with your how iron is mobilized and used up in the body. No, so as we all know, iron is an integral part of your hemoglobin. So before any hemoglobin can be done, no, so iron must be present. So remember that your hemoglobin is your protoporphyrin 9, no, plus your iron becomes your heme, and that heme plus the globin portion becomes your hemoglobin. So any lacking component for that equation will lead to a decrease in overall hemoglobin content in the body, no. So that's why iron is very important, especially when with regards to the hemoglobin production. So if our basis for if the statement that I said earlier is that if you have low iron, no, or there is a poor transport of iron, or there is hoarding of iron, no, na dili siya mahatag sa imong hematopoietic cells, then the ending will be a decreased overall decreased hemoglobin concentration in the blood, no. So what happens is your RBCs are lacking the adequate amount of your hemoglobin. Thus, they are staining quite lightly because they have a decreased amount of hemoglobin within themselves. No, that's why they are hypochromic. They don't stain as much because remember the component that makes red blood cells stain red is your hemoglobin. And if mubo lang siya hemoglobin, then it will not stain as much. That's why it's called hypochromic, low in color, no? And then we have due to the decreased hemoglobin content, no, in the RBCs, it will also lead to a decrease in its overall size. That's why we call it microcytic, no. So there are three conditions affecting iron kinetics, no. So that may result in your microcytic hypochromic anemia. We have iron deficiency anemia. We have anemia of chronic inflammation. It's quite interesting. We'll talk about that later. We have sideroblastic anemias, no, and especially and lead poisoning. So red blood cells in thalassemias may also be microcytic and hypochromic, but this is a different animal from your in your usual problems in your iron metabolism because thalassemias, instead of the iron being deficient, the problem is in the globin portion of your hemoglobin, no? So there's somewhat quantitative problems with your hemoglobin, with your globin production in your thalassemias. No? So iron deficiency results from inadequate iron intake, increased need, no? Kung growing child ka, adolescent, so you need it, or pregnant na mga babae, they need lots of iron because they're not only are they supplying the needs of their child, no, they also need it because they are undergoing changes within their they're undergoing changes within their new physiology as a pregnant woman, no. And then decreased absorption, no? Kung wala kay tinae, no, di naman mo ma-absorb ang iron, no? So that's what happens sometimes when you have a short bowel syndrome, no? You have decreased absorption of iron. Then there's also excessive loss, no? Excessive loss of iron. So in the body, in a male body, the only way that you're gonna lose iron is from your poop, no? So highly unlikely na mag-lose ka og iron, no? Highly unlikely na magka-iron deficiency ka. So in women, so of course, they have a lower hemoglobin than us, not because na kanang not because na mas prominent ilahang pag-lose og blood ay og iron through their menses, no, but because of other factors like hormonal and physiologic. But in comparison to men, women have a monthly routine in a kanang regular menstruating woman na every month naga-shed off din siya og iron, no. So not only is iron an essential micronutrient in the body, it is also a poison, no. So that's why we're making sure that dili siya magsubra-subra sa atong lawas, no. So kato. So the only way you can have excessive loss for iron, no, is number one, very strong menses in women, no, kanang dili ma prolonged kaayo, instead 7 days maabot siya 14 days na menses, no. Number two, na kay mga GI losses, no, na kay mga ulcer sa imong tinae, no, na kay mass dito, na kay tumor dito na naga-constantly bleed, or pwede po ka na bitok, no? Or hookworms are known to urinicator, no? Correct me if I'm wrong, they're able to drink 0.2 ml of blood per worm per day, no? Kung nakay 200 ana, edi nakay 400, 200 pa. Basta daghan kag dugo mawala, no? Kung daghan pud kag bitok, no? So, that's what I'm telling you. So, it's really hard to be anemic if you're a man. So, if nakay CBC na if a healthy male adult or even a healthy female adult with regular menses, so it's really a clue, no, that there's something bigger, there's a bigger problem, no, if you can see that mubo siya og hemoglobin, no. Remember, always remember, dear children, no, the only basis for your anemia is your hemoglobin concentration. So the next slide. So, like I said earlier, infants, children, and women of the childbearing age, no, are at greatest risk for iron deficiency anemia. If iron deficiency is present in men and in postmenopausal women, the possibility of gastrointestinal bleeding should be investigated, although not the only cause of iron loss. No, iron deficiency is suspected when, yes, so of course, like I said earlier, if there are three factors, there are three major components. For me personally, I think better put if you follow me para kanang napamoy general idea, but you can make your own. For me personally, when I think of microcytic and hypochromic anemias, I think of three components, no? The iron, the protoporphyrin, no? And the globin portion. So if any of those three are lacking, then you're gonna expect, especially if it's a prolonged condition, prolonged lack, no, of any of those components, you're gonna consider, you must consider rather, kanang microcytic and you're gonna end up with a microcytic and hypochromic na anemia, no? So, in the case of your iron deficiency anemia, of course, wala kay iron, so that's why dili jud mabuhat imo ang hemoglobin. And since dili mabuhat imong hemoglobin, there's nothing that will fill up your RBCs, making them microcytic, small, and hypochromic, no? There is also an elevated RBC distribution with, no, that's lahi-lahi siya og sizes, and isocytosis, kumbaga. No, diagnosis is confirmed with iron studies showing low levels of serum iron and serum ferritin, no? So serum ferritin is your storage form of iron, and an elevated total iron binding capacity and a decreased transferrin. So your iron binding capacity is the hunger of your body to get iron, no? So kung high siya, meaning you might have a deficiency in your iron, no? So that's why it's really kanang kusog kay sila. Give me that iron, no? Mao taas sila to, mao mo taas na imong TIBC, no? And a decreased transferrin saturation. So your transferrin is your transport type of iron, no? So inadequate dietary iron is treated by oral supplementation with good patient adherence. The anemia should be corrected within 3 months, no? Kana lang siya, ano lang kasayon, no? So that's why kung iron deficiency anemia lang nang nagakos sa imong microcytic hypochromic, maulian jud dapat na siya within 3 months, no? Ngano 3 months man kay 120 days manggod na ang lifespan sa imuhang RBC. So by the time that you have supplemented yourself with a good amount of iron, no, you have you have kanang optimal amounts in your diet. So ang mag-replace sa mga RBC na katong mga microcytic hypochromic kay mga normo-normo na, mga healthy na mga RBCs, they're filled up with iron, with hemoglobin rather, no? So they will replace those microcytic hypochromic anemia, no? So that's why 3 months, no? So gastrointestinal distress during iron supplements can make, actually, no? Share lang ko during duty namo sa aning pagka-doktor, no? You will be asked to assist na mga childbirth, no? So during mga anak ang babae, no? So one of the kanang strict requirements namo sa perinatal namo na mga screening and perinatal na mga check-up, no? Kay dapat mag-inom siya og iron supplements. So kung makakita ka kanang na may time na mag-poop sa ang babae before mo gawas ang bata, no, pag makita nimo ang tae dili lagom, no, dili tari, subutan na wala siya gainom sa iyang supplements mo. So dili po ta makaingon na 100% wala siya gainom, but highly unlikely, no, because what happens with iron, it is irritating to the gastrointestinal tract, manggod. It makes your poop black, no, and very stinky, no. So that's why maybe it's really hard for patients to adhere to it, no. So kato goods. So mo ni siya iron regulating systems nato. I think you already covered this in your hemoglobin synthesis na topic, no, in hema 1 sa normal. Alright, let's go. So tinae nimo iron, no, sulod siya sa imuhang enterocyte, which is your lining of your colon rather, lining of your colon. And then after niya sulod, mahimo siya og TF transferrin, no. So mubahin siya sa imong transferrin, no. So transferrin is a protein, no. So dili man guni pwede mag lutaw-lutaw lang ning iron as itself, no. So kailangan buyog ni siya sa transferrin, no. So transferrin, no, so maato ni siya sa bone marrow naman ni siya, maato siya sa developing RBC para i-incorporate sa imong hemoglobin, then mahimo siyang circulate. Sorry, wala day ko pen. So here, no, so from your tinae sulod sa imong lining epithelia sa imong colon enterocyte, maghimo siyang magbind siya to your plasma transferrin, imong iron, and then i-incorporate siya sa imong developing RBC, mag-circulate siya in life, no. Tapos after, pag time na niya mamatay, mato na siya sa spleen. Also always remember, your spleen is your RBC's graveyard. Kay patcho na siya once mahimo na siyang senescent, no. After niya patchon sa macrophage dito sa spleen, no, makuha to niyang iron katong transferrin, no. Transferrin nagikan sa napatay na RBC, maadto siya sa hepatocyte, and then via the action of your hepcidin, no, ato siya sa hepatocyte. Kanya depende lang po na sa hepcidin kung i-release na po niya balik sa imong developing plasma cells. So your hepcidin is a hormone, no, that will either inactivate the absorption and recycling on iron by the enterocytes, macrophages, no. So when the body iron decreases, hepcidin will also decrease, no. Remember that your hepcidin, it makes iron absorption down, no, and it makes the iron within your macrophages stay, no. So dili siya ma-incorporate sa imuhang developing RBCs. We will talk about why it does that, no, what's its purpose, no, later. Later, yo. Ay, napaday din yo. So over here we have another table, kumbaga. So first, there will be a decrease in body iron, no? So in your liver, and your liver will decrease hepcidin, no. And then the decrease in hepcidin will stimulate your enterocytes, macrophages, and your hepatocytes to create the ferroportin. Ferroportin is a transfer channel to transport iron out, no. So once na okay na ilang the ferroportin is patent and ready to go, no, iron absorption and in intestines and iron release from storage occurs, and then mag-increase na imuhang body iron. And once your liver finds out about this, no, so magproduce na po siya og hepcidin to regulate itself, no. Iron is very regulated because not only is it beneficial, it's also toxic in copious amounts, no. Apart from that, many microorganisms thrive when there is lots of iron, no. So that plays a part in a different type of anemia later, no. So we have our iron compartments in normal humans, no. So are functional. So the most abundant place no, where iron is found, it's in your blood, ha, in your hemoglobin, and we have our myoglobin in our muscles, no? So we have peroxidases, catalases, no? We also have our cytochromes in our liver, cytochrome C, no? So 68% is found in your hemoglobin. Storage is our ferritin and hemosiderin in macrophages and hepatocytes. And our transport is, like I said earlier, transferrin. So the absorption of iron in the small intestine, no, over here, absorption of ouch. So the absorption of iron in your intestine occurs when in the lumen, no? Uh, Never mind. So this is the lumen. This is where your food is at, no? What will happen? Your ferric iron, no, is converted into ferrous, no? So Fe3 to Fe2, and then your divalent metal transporter will, once it undergoes its conversion, no, reduction ba na? I don't know. Oxidation. Wait, check na to. Oh, okay. Ferrireductase, no? Reduced na siya to ferrous. Then your divalent metal transport will be able to recognize it and pasudlo na siya, no? So once inside, then it will become either it will be it will be converted into ferritin, no? It will be bound to ferritin, or it will be pushed outside in the basal area through ferroportin, no? This ferroportin is the presence of this ferroportin is dependent on hepcidin. Kung wala hepcidin, meaning naay ferroportin. Pero kung naay hepcidin, wala ferroportin. Okay, remember that, ha? So if naay ferroportin, magawa siya as ferrous, no? Ferrous, and then it will be converted by your hephaestin to ferric. Then it will be bound to your transferrin. Alright? So, advise you, if malibog mo, kanang read it on your own, and then pwede mo mag-ask ako, tapos you can PM me, or kanang i-read lang ninyo din. Either way, I'll make the quiz easy. I won't boggle you with such things, no? Anyway, next, anemia of chronic inflammation is associated with chronic infections such as tuberculosis, chronic inflammatory conditions such as rheumatoid arthritis, and malignancies. It may be microcytic, hypochromic anemia. Often, it is a mild normocytic normochromic anemia. So ngano man ka magka anemia of chronic disease, no? What's the point of this, no? So what happens when you have inflammation? There will be an increased amount of hepcidin, no? As we all know, hepcidin is a kontrabida of iron kanang metabolism, iron absorption, and iron release from your macrophages, no? So what's the purpose of this hepcidin? Di ba I mentioned ganiha that microorganisms enjoy an iron-rich environment because that will also aid in the synthesis of their enzymes, no? And once their enzymes are kanang fully functional with this iron that they have gathered, they'll be more they'll be more active in dividing and multiplying, no? So what happens is hepcidin tries to counteract that vigor that they have from the increased iron, and then they try to hoard all the iron para dili makamit sa imuhang mga kagaw, no? So in the process, no, ideally mag-inflammation manggod ka, taas na manggod kayo ng 1 week. So dili dapat na siya mudugay for long. But in the case of your TB, it's a chronic disease jud, maabtan yung kag bulan ana, no, na kay mga arthritis, na mga rheumatoid, no. Prolonged inflammatory processes will always stimulate an exponential increase in your hepcidin, no? Magkadugay na imuhang inflammation, magkasamot, magkamubo na imuhang iron. So that's why you're gonna have this what we call anemia of chronic disease tungod sa prolonged secretion of hepcidin. Your iron stores are high, no? So what will happen here, na kay iron, dili lang siya ma-incorporate into your hemoglobin. Eventually, yung ending ani, wala na po, mubo na po kayo kaog hemoglobin. So, bone marrow macrophages show abundant stainable iron, whereas developing erythroblasts, no, show inadequate iron. So, in the bone marrow, this macrophages manggod, they are what we call the nurse cells, no? They are the ones that nurse the developing erythroblasts. They are the ones that give these erythroblasts their iron, no, to produce their hemoglobin. Kung naay hepcidin magdinalo ng macrophage, di na siya maghatag og iron sa imuhang RBCs, no? So we have iron restricted erythropoiesis, no? Inflammatory cellular products also impair the production and action of erythropoietin, no? Erythropoietin is a stimulant for your erythropoiesis, no? Iron studies in the anemia of chronic inflammation show decreased iron level, decreased TIBC. Why is it decreased TIBC, no? So meaning dili gutom imuhang lawas for iron because it knows it has a lot of iron, no? So dili siya mag-increase imong TIBC compared to your iron deficiency anemia, no? So decreased or normal transferrin saturation, meaning daghan kag iron sa imong transferrin, and normal or increased ferritin level, no? Ferritin is your storage na iron. So this is the development. So remember ha, so iron deficiency anemia, pasabot ana wala lang jud kay iron na gina sa intake nimo, no? Wala kay iron sa imong intake via sa imong diet, or sige lang kag kalibang, no, sige lang kag bleeding, no, nakay bleeding na dili controlled, so you're gonna lose RBCs and you're gonna lose your iron through that. So in your chronic anemia of chronic inflammation, na kay iron, dili lang siya ma-incorporate through to your RBCs kay magdinalo imuhang mga macrophage and dili pud mo absorb imuhang colonic villi, no, kay tungod sa hepcidin. Hepcidin makes the macrophages hold onto iron, no? It also down regulates the formation of your ferroportin, thus dili ma-release to imuhang iron in your lining epithelia to the blood, no? So kani ato ang mao ni akong guwapa na table no siya. So this is the normal iron table nato ni siya on the stages of iron deficiency anemia. We have normal iron status, no. So normal ni siya tanan, kaniyang normal, no, guwapa ni siya pak. Hemoglobin normal, iron normal, TIBC normal, ferritin, serum transferrin, yeah. Hemoglobin content of reticulocytes, no. In your stage 1, no, dili man ka mag-microcytic hypochromic dayon, kalit lang ka maluya, dili man. So there are compensatory protocols pa to buffer there, because there are sometimes na mubo jud imong iron na ma-intake, no. Sa una siguro to karon kay dali lang man kayo ta makakuha og iron, no, naman na sa meals, sa meat natong ginakaon, sa gulay, no, naputay mga iron supplements, no. So stage 1, no, storage iron depletion. So latent storage iron pa lang ang nawala, no, wala pa tay ang storage pa lang. So remember that you have your your ferritin as your your storage type of iron, no. So kana pa lang siya ang nahinay-hinay, no, because there is no longer there is already a deficiency in the iron. So ang imuhang tinigom sa na iron ang i-use up for erythropoiesis, no. So that's what we call your latent iron deficiency. It's still your latent iron deficiency. So what will happen, this is your graph, no, iron storage compartment. Naog na siya, naganaog pa siya, So your iron transport compartment, meaning your ferritin, is still normal. Your ferritin normal. And your functional iron compartment, that is your RBCs, still normal. So more or less normocytic, normochromic pa kaani. You won't find if ever you're in a storage iron depletion phase, no, your stage 1, your RBCs are still normocytic and normochromic. Your hemoglobin content is normal, no, but you need to you will only find this. It's really hard to diagnose. You'll only find this if you undergo specific tests like your ferritin, no. So what will happen is everything is normal except your ferritin na nag-decrease and your serum transfer ay so sorry soluble transferrin receptor di ay sorry dili din siya transferrin, no. So your serum ay soluble transferrin receptor, it will increase, no. So why will it increase? Because it will compensate, no, because it needs more transferrin, no, that has iron. But tungod kay nagahinay na kanaog yung transferrin, that's why the body is trying to compensate, makes more receptors, trying to cast a bigger net. But wala na siya makuha. Ay, for now, stage 1, napa siya makuha kay napa man kay storage. Eventually, down the road, it will eventually be hubas na tanan, no? In your stage 2, your transport iron depletion, no. So what will happen? Daog na pud imuhang mga transferrin na component. So in this stage, if your iron storage, all your ferritins are wala na, then we will get from your iron transport compartment, no. That's your mga transferrin na to, no. So what will happen? Normal gyapon imong hemoglobin, normocytic, normochromic gyapon ka, but your serum iron is decreased na, your total iron binding is increased na kay di ba gutom na ka og iron. Ferritin is of course down. Your soluble transferrin receptor is of course up, same with it has the same explanation. But the hemoglobin in your reticulocytes is already going down. Meaning, ang imuhang RBCs na ani na time, di ba naman kay 120 days sa imong RBCs. Ang mga RBCs na ani na batch, kompleto pa sila hemoglobin, no. But sa next batch, imuhang reticulocytes, no, gamubo na, no. So in our final stage, no, functional iron depletion, this is your full-blown iron deficiency anemia. Excuse me. So your hemoglobin is finally down, and everything is same with stage 2. So kanina din ako makakita og microcytic, hypochromic, no, na RBCs. So what are the next is the Cedaroblastic Anemias, no. So when the synthesis of the protoporphyrin or the incorporation of iron into protoporphyrin is blocked, no. So what will happen is you have iron, no, you have globin, but your protoporphyrin, there is an issue regarding the protoporphyrin itself, kung mabuhat ba siya, or there is poor kanang incorporation of iron into your protoporphyrin 9. Ay, not necessarily 9, because what if before pa siya, wala pa siya naabot ng stage na 9, dili na siya na-produce, no? So the result is there is an accumulation of iron in the mitochondria in the developing erythroblast, no. Nucleated pa ni sila ha, sa bone marrow ni siya makita, no. So when stained with Prussian blue, the iron appears in deposits around this nucleus, no, these blue ones, no. So these are called ring sideroblasts, no. So they're sideroblasts, meaning they have lots of iron, sidero meaning iron, and they accumulate near the mitochondria. So what's your stain gani? Prussian blue. Protoporphyrin synthesis and iron incorporation into the protoporphyrin can be blocked with any of the enzymes. So daghan man nag-enzyme sa imong synthesis, no, and they are either deficient or impaired. Deficiencies of these enzymes may be hereditary, such as in Porphyrias, or acquired, as in your heavy metal poisoning, also known as your lead poisoning, no. So the most common na imong heavy metal poisoning is also lead, but dagag heavy metals na makakos ani. So, iron studies in your sideroblastic anemia show increased levels of serum iron, meaning unsa ka kanang grabe imuhang storage siya sa iron kaya di lagi siya ma-incorporate into your erythroblast, no? So you also have a decreased or normal TIBC, no? Meaning the body isn't hungry for iron because it has a lot of iron, di lang siya ma-incorporate into your protoporphyrins, no? So and then there is also an increase in your transferrin saturation. So you really have lots of iron in this problem, no, in your sideroblastic anemias. So test values for accumulating products of the heme synthetic pathway such as zinc protoporphyrin or free erythrocyte protoporphyrin is also elevated, no. So why are they increased? Because kaning zinc protoporphyrin or free erythrocyte protoporphyrin, they are converted kanang to measurable na mga type of protoporphyrin, no. So if immature pa siya na protoporphyrin and kulang isa ka enzyme, dili siya mag-mature. So ang ginabuhat sa body, mag-create pa siya og ato na immature na type of protoporphyrin, hoping na enzyme na ma-produce so that it will progress into a mature protoporphyrin. But kato lagi, since kulang imuhang enzymes, dili tanan na nabuhat na immature protoporphyrin ang mahimong mature na mag-bind sa imong iron. So there will be a build up of this immature protoporphyrin. So that's why there is an increase in your ZPP and your FEP, no, free erythrocyte protoporphyrin. The meaning of free erythrocyte protoporphyrin is just it's a protoporphyrin that is outside your red blood cell, no. So lead interferes with several steps in the heme synthesis, no, preventing iron incorporation into the heme, resulting in a normocytic normochromic anemia. Although with long-term exposure, it can be microcytic and hypochromic, no. So eventually it will become microcytic and hypochromic because there is no hemoglobin formation. Lead also impairs the pentose phosphate shunt, which adds a hemolytic component to the anemia, no. So remember, one of your hemolytic anemias is caused by your impairment of your pentose phosphate shunt, leading to the decreased production of your ATP, making your channels, no, your sodium potassium pumps unable to sustain themselves, leading to hemolysis, no. Children are especially vulnerable to the effects of lead on the central nervous system, which may result in irreversible brain damage. So, of course, the treatment should be removal of lead, no, and a chelating drug because it's a heavy metal, no. So, next is central nervous system's effects are typically not reversed with treatment. So the next condition we're gonna talk about is the porphyrias, no, are diseases in which the porphyrin production is impaired. So they can be acquired, such as lead poisoning, or inherited through mutations of specific enzymes in the heme synthetic pathway, no. So there are 3 hereditary porphyrias that have hematologic manifestations, including anemia, fluorescent erythroblast, no. So this is the same explanation with your sideroblastic anemia ganiha na there will be an accumulation of immature porphyrins, no. So your porphyrins are a lot, no. So even in the chapter dili na nato siya delve into kayo. So because the body has no mechanism for iron exhaustion, iron overload can occur. So to sustain iron overload can occur when transfusions are used to sustain the patients with chronic anemia such as beta thalassemia major, no. And then iron loading anemias, those with erythroid hyperplasia that increases the levels of erythroferrone, leading to increased hepcidin, increased ferroportin, and increased iron absorption. So simply put, your porphyrias lead to lead to a decreased production of your porphyrins, no, leading to poor or weak na incorporation of iron into the protoporphyrins, leading to a decrease of total hemoglobin. No, so this is a separate topic. Hopefully, we're gonna talk about this next time. No, so ano siya? So this is just a simple table for your chronic infection leading to increased hepcidin. No, we talked about this late kaniha naman. So defective ano sabi? What? HFE gene, no, can lead to hereditary hemochromatosis by decreased hepcidin production. No? So meaning if wala kay hepcidin, no, if you don't have hepcidin, meaning you will have an overabundance of iron. No? So that's why you have that's why what we have hemochromatosis, meaning sobra-sobra kayo imong iron. No? So the mutations of this hemochromatosis is very dangerous because the iron can deposit in your multiple organs. No, we all can deposit in your brain, deposit in your liver, in your heart, no, in your bone marrow. So mutations of other genes affecting iron regulation can produce a phenotype similar to hereditary hemochromatosis. When the hepcidin or hemojuvelin gene is mutated, this disease develops early in life, affecting even teenagers. So like this. So the liver, pancreas, and skin and heart muscles are especially vulnerable to damage by excess iron deposition. Like I said earlier, iron must be regulated because iron in excessive concentrations is a poison. Kumbaga. So hereditary hemochromatosis and similar diseases, no, are treated by lifelong periodic phlebotomy para makuha lang tong iron, no, and to induce a mild iron deficiency and keep the body iron levels low. Transfusion-related hemosiderosis must be treated with iron chelating drugs. So one of the examples of our iron chelating drugs is your deferoxime. Kato basta iron chelating to siya. So chelating agents, no? So the most common chelating agents in medtech is of course your EDTA, no? So kato. So kato I have another topic. So katong mga globin, so it will be in a different video. So I hope if you have any questions, feel free to ask me. And if wala na, bye bye guys, God bless. I hope nakatuon mo.